Hello and welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Sangeeta Krishnan, medical editor at MIMS Learning, and joining me in the studio today is my colleague Dawn Liz Powell, another medical editor at MIMS Learning.
Hi.
So what an exhausting week this has been.
Well, if you must insist on having children, what do you expect? I'm still tired from that one time I looked after my niece when her sister was being born.
Looking after your niece is one thing, but as I'm sure you heard from many parents before, being a parent and having a full-time job, it's like being on the clock 24/7. That said, it's one thing to be tired because of the daily demands of life, but feeling so tired that you're struggling to function every day could be a sign of an underlying issue.
Absolutely. Tiredness is a fairly common symptom GPs encounter in practice. If a patient is reporting to their GP that they feel tired all the time, they presumably have already thought about the possible causes for this and tried to address them. For example, if they've been burning the candle at both ends, try to take it a bit easier. But in the context of this podcast, we're talking about the tiredness that is disproportionate to how much sleep a patient at least thinks they're getting and or how much they're exerting themselves. For example, feeling tired after a run is normal, but feeling tired after a 10-minute walk is less so.
Let's look at what that could mean from a clinical perspective. We will look at some of the common causes of tiredness and fatigue, including sleep apnea, nutritional deficiencies, thyroid problems, and more chronic conditions like myalgic encephalomyelitis or chronic fatigue syndrome, or ME/CFS.
We'll also touch upon the distinction between tiredness because of sleep deprivation and tiredness despite having sufficient sleep.
That's a lot to discuss, so let's dive right in. The first thing when a patient presents with tiredness is to take a good history. In her module on the red flag symptoms of tired all the time, Dr. Suchita Shah says, taking a good history is essential to narrowing down a potentially enormous array of differentials.
Yes, as ever, individualised care is paramount. So let's assume the history suggests hypothyroidism. It is one of the more common endocrine disorders, and it consistently appears in discussions about fatigue. Hypothyroidism, of course, means you have an underactive thyroid, a topic we have actually covered in some of our past episodes, and we do have several modules on MIMS Learning about. Common symptoms include fatigue and feeling sluggish, and patients may also report unexplained weight gain, that they have become sensitive to cold, and they have general aches and pains.
The diagnosis is pretty straightforward, with a blood test to check thyroid function, specifically TSH and free T4 levels. Management typically involves thyroid hormone replacement therapy, usually with levothyroxine. Thyroid function should also be monitored regularly, and the dose may be adjusted as needed.
Okay, so as I mentioned, we talked about hypothyroidism in a previous podcast, and we do have several modules on MIMS Learning about the condition. So if you want more information, do check those out. So the hypothyroidism can cause fatigue regardless of how much sleep the patient might be getting. But what about tiredness that is directly related to lack of sleep? Sangeeta, you mentioned obstructive sleep apnea as a potential cause of fatigue. And obviously, if your sleep's being disrupted, that will lead you to be feeling tired. Shall we expand on that?
Sure. So obstructive sleep apnea syndrome, or OSA, is part of a disease spectrum referred to as sleep disordered breathing. It encompasses central sleep apnea, snoring, respiratory-related arousals, and hypoventilation. Patients with OSA often experience disrupted sleep due to apnea, leading to brief awakenings throughout the night, even if they're not fully aware of them. Often, people may not even recognize that they have any symptoms other than snoring. When should a clinician suspect OSA as a cause, Dawn?
Well, according to the NICE guidance on OSA, a sleep history should be taken if a patient reports things like their partner has witnessed them having an apneatic attack, they are experiencing unrefreshing sleep, and or they have woken up choking after falling asleep. I mean, NICE has a whole list of features that could indicate OSA, but importantly, to suspect OSA, patients need to report at least 2 of these features. NICE also says that certain people have a high prevalence of OSA. I think it's fairly well known that people who are living with obesity or who are overweight are at increased risk of OSA, but people with treatment-resistant hypertension or type 2 diabetes are also increased risk. Though, of course, if they have type 2 diabetes, the likelihood is that they will have a higher BMI anyway.
Yes, and there are also screening tools such as the Epworth Sleepiness Scale to predict the risk of OSA. If a patient scores more than 10 in that questionnaire, they should be referred to secondary care. It must be said that road traffic accidents are more frequent in patients with OSA, and a study published in Thorax found that the driving performance of these individuals is comparable to those under the influence of alcohol. And so the DVLA has specific regulations for patients with excessive sleepiness, even if it is mild. For example, patients with mild OSA with excessive sleepiness must not drive until the excessive sleepiness is controlled. If the symptom remains uncontrolled after 3 months, they need to notify the DVLA of their condition. Those with moderate to severe OSA with excessive sleepiness must not drive and must notify the DVLA. Dawn, can you tell me what the treatment is for OSA?
Treatment tends to differ depending on the severity of the OSA. For people with mild disease, it's usually just lifestyle changes, such as reducing BMI, if that's applicable, but the daytime sleepiness can make reducing BMI challenging. Presumably, this is because if they're feeling sleepy, they're going to struggle to participate in exercise. Other lifestyle modification factors that need to be considered is like smoking cessation and or avoiding drinking alcohol in the 2 hours before going to bed. The module we have on OSA states that the use of sleeping tablets and sedatives should be avoided, but if a patient is taking them, reduce them to the lowest dose. But in terms of actually treating the OSA, so this is people with more severe forms of the disease, continuous positive airway pressure, or CPAP, is considered the gold standard treatment. Therefore, it's widely used as the first-line intervention.
Thanks, Dawn. We've seen hypothyroidism as a condition that can cause tiredness, and we've looked at when tiredness can be mistaken for daytime sleepiness. Let's shift the gear back to tiredness without sleep deprivation. What could be some other possible causes of persistent tiredness?
Well, of course, there are a host of potential causes, some more sinister than others. For example, persistent tiredness can be a red flag of underlying malignancy. NICE does have some guidelines on suspecting cancer.
Yes, and they state that lung cancer or mesothelioma should be suspected in case of unexplained fatigue in people aged 40 years or older who have ever smoked, or in persons aged 40 years or older with fatigue accompanied by cough, shortness of breath, chest pain, weight loss, or appetite loss that is unexplained. Mesothelioma may be suspected in someone aged 40 years and over with unexplained fatigue with known exposure to asbestos. These patients should be offered an urgent chest X-ray. Persistent fatigue in adults can also be indicative of leukemia, and NICE recommends getting a very urgent full blood count within 48 hours if leukemia is suspected. In women aged 18 years and over who experience persistent fatigue, ovarian cancer should be considered, and serum CA-125 and other tests can be carried out in primary care.
I presume that fatigue alone would not be enough to suspect ovarian cancer in a woman, because I think fatigue could be caused by so many other things. Or at least ovarian cancer would be something to consider once the other non-malignant causes have been ruled out. That does bring us to nutritional deficiencies, as these can often present with tiredness. Iron deficiency anemia is, of course, the classic example, particularly of women of childbearing age, those with heavy menstrual periods, and or individuals with poor dietary intake.
You're absolutely right, Dawn. And symptoms of iron deficiency anemia can include fatigue, of course, as well as pallor, shortness of breath, and headaches. A simple blood test, including a full blood count and ferritin levels, can help with the diagnosis. Treatment often involves iron supplementation and addressing the underlying cause of the deficiency.
And it's not just iron deficiency. Vitamin B12 deficiency can also lead to mental health and neurological problems such as cognitive impairment. Treatment with B12 replacement is effective, but some people will need adjustments of the dose, frequency and route to optimise absorption. Fun fact about the well-known brand of spreadable yeast extract, the one you either love or you hate. It's such a great source of B12 and other vitamins that it has been used to treat malnutrition. Of course, we should mention it also has a lot of salt.
Yeah, as a vegan who's very clued in about the fact that I need to supplement B12, I always keep stocked up on plenty of yeast extract.
Me too, actually. I do actually have it for breakfast every day. But back to the topic at hand, NICE recommends testing for vitamin B12 deficiency when a patient presents with unexplained fatigue, there is abnormal findings on blood count, such as anemia, and or the patient experiencing cognitive difficulties, such as poor concentration or has experienced short-term memory loss. Testing is also recommended if there are neurological or mobility problems related to peripheral neuropathy or to CNS disease, including myelopathy, impaired gait, and paresthesia.
Vitamin D deficiency is another common culprit, often presenting with fatigue and muscle aches. Of course, the NHS recommends that everyone during the winter take a vitamin D supplement. It's also worth finding out if the patient has any malabsorption issues or if they ever had bariatric surgery.
Absolutely. Of course, diabetes can be a cause of tiredness as well, but there are probably other things, such as frequent urination at night, that might be more suggestive of diabetes. So we have talked about tiredness with an identifiable and potentially treatable cause, but there are conditions that are associated with fatigue, often debilitating fatigue, that do not have an identifiable cause. I'm thinking of conditions like long COVID, ME, or CFS. ME/CFS is a complex chronic condition affecting multiple systems and can range from mild to severe.
According to our module on the NICE guidance on ME/CFS by Dr. Tony Hazel, debilitating fatigue, post-exertional malaise, unrefreshing sleep, and cognitive difficulties must all be present for a clinician to suspect CFS. These symptoms, if present for 3 months or more, can be used to suspect ME/CFS in the absence of any other underlying cause. It is a diagnosis of exclusion, meaning it can be diagnosed in primary care through a full history, examination, and screening blood test. ME/CFS can also be associated with orthostatic intolerance, temperature hypersensitivity, neuromuscular symptoms such as twitching, flu-like symptoms, chronic pain, intolerance to alcohol, and changes in sensitivity to light, touch, sound, taste, and smell.
That all sounds incredibly challenging. Having a condition like that must really affect the quality of your life. It would affect your ability to work, and also it would have a massive effect on your family because they might be then having to care for you.
Yes, and this is definitely a concern. NICE actually mentions that there is a risk of these symptoms being confused with signs of abuse or neglect. It says that the following are not necessarily signs of abuse or neglect: physical symptoms which don't fit a commonly recognized pattern, more than one child or family member having CFS, parents or carers disagreeing with professionals or withdrawing from a care and support plan, parents or carers acting as advocates for their child or communicating on their behalf, and reduced or non-attendance at school.
Okay, so talking about management now, given there is no identifiable pathological cause of ME/CFS, there are no pharmacological treatments aimed at treating it, and unfortunately no drugs are in development. Therefore, management is focused on the symptoms, such as managing energy levels within a patient's own limits and being aware that flares or relapses take time to recover from, getting enough rest, and using multidisciplinary services such as occupational therapy and physiotherapy to maintain as much physical function and mobility as possible. There's been a lot of historic stigma about ME/CFS being a made-up condition or a mental health condition. For this reason, any discussion about psychological therapies, about cognitive behavioural therapy, needs to be handled extremely carefully. Essentially, I think NICE advises that CBT can be offered as a supportive therapy that may help patients to manage the symptoms, but it should not be suggested that it's a treatment or a cure.
Interesting. Thank you for joining me on this discussion, Dawn. So, what have we learned today? First, we learned that tiredness can be from sleep deprivation because of conditions like OSA. OSA can lead to significant daytime fatigue, and the condition can be treated through lifestyle modifications and CPAP. Second, nutritional deficiencies such as iron, vitamin B12, and vitamin D can contribute to fatigue and require appropriate supplementation based on diagnostic findings. Endocrine causes like hypothyroidism and diabetes are also common causes of fatigue. And finally, MECFS is a complex, multi-system condition characterized by severe, persistent fatigue and post-exertional malaise. It is a diagnosis of exclusion, and there are no pharmacological options available to treat it. Treatment is through managing energy levels and using multidisciplinary services such as occupational therapy and physiotherapy to maintain as much physical function and mobility as possible. A thorough history, physical examination, and appropriate investigations are essential in determining the underlying cause of persistent tiredness. Don't forget that you can claim CPD credits for listening to this podcast, so be sure to go to mimslearning.co.uk to download your certificate and find links to useful resources and further reading. Thank you for listening in. We've been the MIMS Learning editorial team, and this episode was produced by Jude Owen. Tune in next week as Rhiannon Ashman will be talking to gynecologist Dame Leslie Regan about miscarriage. See you next time.